In another interesting talk, we are going on to the debate in which two great and young speakers will be there, Dr. Vasudha and Dr. Vignesh. So starting the debate will be with Dr. Vasudha. She is a trained, she's working at Rainbow Children's Hospital, a hematologist, and she has been trained at Great Ormond Street in UK. So Dr. Vasudha, please.
Thank you, sir. Good evening, everyone. A big thank you to the organizers for having me on board for such a niche conference. I hope I'm audible and my slides are visible. I'm from—
Yes, you are, please.
Yeah, so I am from a pediatric hemato-oncology background. Sorry, just one moment. Yeah, that's better. So I'm from a pediatric hemato-oncology background, and I will be proving my point for the use of HLH protocols, HLH 2004 and 94 in the management of secondary HLH in PICU. So from all the talks, the superb talks that we have had so far, I think we have understood HLH, CRS, MAS, whatever you want to call it, really well. It is an acute and rapidly progressive syndrome, or an umbrella of syndrome, so as to say. And
slides are not moving, Dr. Vasudha.
Slides are not moving.
You'll have to make it full screen, not the presenter view.
No, I have made it full screen itself.
Just exit the presenter view and go on to...
Now?
No. Right now you're in presenter view. Yeah.
No, I have exited the presenter view actually.
Just go to full screen. Or probably just close the presentation and open it again.
Sure. Just one moment.
Recording in progress.
Vasudha, you need any help?
No, sir. Just give me a minute. Just trying to open my presentation again. Is my screen visible now?
Not yet.
Not yet. It's still opening.
We could probably go to Dr. Vignesh's presentation and come back to you next, if that's okay.
Yeah, sure. I think that's a good idea. So
sure.
Maybe Dr. Suman.
Yeah. It gives me great pleasure to introduce Vignesh to this forum. Dr. Vignesh Pandyarajan did his postgraduate in postgraduation in pediatrics from ICH Chennai, and then completed his DM in pediatric clinical immunology and rheumatology from PGI Chandigarh. He is a young guy, but wears a number of very, very exclusive hats. He's a co-chair of the APSID Juniors Working Party 2020 to 24, Indian representative for APSID Juniors 2020 to 2024, and an executive board member, North India Indian Society of Kawasaki Disease. He has about 120 publications in national and international journals to his credit. His areas of interest are primary immunodeficiency diseases, especially CGD and combined immunodeficiency disorders, and juvenile dermatomyositis. Pleasure to hear you, Vignesh. Over to you.
Thank you, ma'am. Am I audible and is my screen visible?
Yes, Vignesh.
Thank you. So thank you, organizers, for having given me this opportunity and for giving me this interesting debate between the cytokine blockade versus the HLH protocol in the management of secondary HLH. So I'll be talking in favor of cytokine blockade, being an immunologist. So just a quick summary of the etiology of HLH. The article, it says it's a spectrum of cytokine-driven immune disorders. So this slide we have been seeing for the last 3 days. The triggers could be genetic, the inflammatory disorders, autoinflammatory disorders, and several infections, and as well as malignancies. So let me quickly dive into the etoposide. That's a key molecule used in the HLH 2004 as well as the previous 94 protocols. So if we look into the mechanism of action, so it inhibits the topoisomerase 2. So this topoisomerase 2, what it does is it creates the DNA break, and it also reseals that is necessary for moving the cell to the mitosis phase. So what does this etoposide do? It blocks the topoisomerase action. So it creates the breaks. It induces the double-stranded DNA break so that the cell doesn't go into mitosis, and thereby inhibiting the cell proliferation. So this is basically the mechanism of action of etoposide. So the where does the etoposide initially came into the picture in hemophagocytic lymphohistiocytosis? The history dates back to 1980 and 1986. This formed the basis of the subsequent 94 protocol. So initially, the hemophagocytosis is thought to be an infiltrative pathology like a cancer. So that's why the chemotherapeutic regimens have been used and have been shown to have some form of benefit. So that has led to the subsequent 94 and the 2004 protocol. And subsequently, it has also been shown that it just selectively ablates the activated T cells. But one should remember that secondary HLH can occur with T cell immunodeficiencies as well. So we have patients with severe combined immunodeficiency where the T cell count is less than 100. They also develop features of hemophagocytic lymphohistiocytosis. So it is not just the activated T lymphocytes that play a role in the pathogenesis of hemophagocytic lymphohistiocytosis. And the most important component of etoposide is the side effect. So more than 10% of the patient, they develop leukopenia, they develop nausea, vomiting, cytopenias, alopecia, anorexia, diarrhea, leukopenia, and many patients also develop stomatitis, around 6%, and also hepatitis. So it's also a dilemma when you use etoposide in a child with HLH and subsequently the child develops hepatitis and cytopenias. You always scratch your head whether this is a etoposide related or it is a ferritin related side effect. But the most important here is the development of infections related to the neutropenia. So this is the long-term follow-up of patients who were treated with the HLH 2004 protocol. So this is the mortality data that is given in this study published in Blood. So here we can see that in the initial 2 months, the mortality was seen predominantly in patients who do not have familial HLH. That is nothing but our secondary HLH. So in the first 2 months, so what if we look into the etiology of the mortality of these patients who had secondary HLH, so it's reported as septicemia, infections, and bleeding associated with treatment toxicity. So this mortality is much higher in secondary HLH compared to the primary HLH group, where the mortality is lower in the first 2 months. And the most important point to be noted here is one patient also developed acute myeloid leukemia after 2 years of receiving etoposide. So etoposide is not a drug to be taken as light. And subsequently, we have this publication from Turkey, secondary hemophagocytosis, do we need really chemotherapeutics for all patients? So this is a study which assessed 12 children with secondary HLH. And the physicians have used the less immunosuppressive therapy like steroids and IVIG and has shown a 83% survival. And in this study where 2 patients in whom the HLH 2004 protocol has been used, both the patients have expired. So this again suggests that HLH 2004 protocol may not be the regimen to be used in secondary HLH. So over the years, we have learned the immunopathogenesis of HLH. So we know it's the CD8 T cell hyperfunction, which leads to the excess production of interferon gamma, which activates the macrophages, which initiates the positive cascade. The activated macrophages, it stimulates the CD8 T cell, which again is not able to effectively produce the granzymes to kill the antigen-infected cells. In turn, it produces interferon gamma. So it is the cytokine cascade that occurs in HLH that results in the manifestation of vasculopathy, coagulopathy, organ damage, shock, hepatosplenomegaly, and hemophagocytosis. So this is a simplified version of the cartoon. So if we see the predominant cytokine produced by the defective CD8 T cell is the interferon gamma, which results in the increased macrophage activation and expansion. And this leads to the production of various pro-inflammatory cytokines, resulting in activation of the immunological cells. And so this is why this phenomenon is called the cytokine storm. So, and we can block the different steps, the different cytokines, or you give the regulatory cytokines IL-10. So this is briefly reviewed in this review article. So mainly what we will be seeing is the anti-IL-1 agent, that is the anakinra canakinumab. I will not be going into details of that because Dr. Randy Cron's talk is to be followed after my talk, and he will be detailing on these medications. We have anti-IL-6 agent, that is tocilizumab, JAK inhibitors, ruxolitinib, and anti-interferon gamma, Impellumab. So this is the gene expression profiling of peripheral blood mononuclear cells from children with active hemophagocytic lymphohistiocytosis. This side, the A panel, it shows the genes that are downregulated, and in the panel B, we see the genes that are upregulated. So we can see the IL signaling molecules, IL-10 signaling, and the IL-1 signaling. These are upregulated in children with hemophagocytic lymphohistiocytosis. So this is the study. Dr. Khanna also highlighted this, and I'll be just showing this slide where the beneficial effect of anakinra has been documented in secondary HLH. So this is the study by Dr. Randy Cron. So here the investigators have shown that earlier initiation of anakinra was associated with reduced mortality in these patients. And considering the underlying diagnosis, the systemic JA, the systemic juvenile idiopathic arthritis patients had the lowest mortality rate. And anakinra appears to be effective in non-malignancy associated pediatric secondary HLH when it is given early in the course and in patients with underlying rheumatic disease etiology. The other important cytokine in HLH is the interferon gamma. So I've already told this, the cytokine is produced by the CD8 cell. And this is the mice model, which shows that after the infection of the perforin deficient mice, the interferon gamma levels goes up, and this interferon gamma levels come down with the infusion of monoclonal antibody to CD8. And the authors propose that in perforin deficient CD8 T cell, it is the hyperproduction of interferon gamma that results in the subsequent downstream cytokine toxicity and hemophagocytosis in patients with perforin defect. So we have JAK inhibitors. So what is its connection with interferon gamma? So interferon gamma, it signals through these receptors. These are the interferon gamma receptors, and this receptor is coupled with JAKs and STAT. So this is how the cytokines, it acts through the cell receptors and the subsequent signaling from the receptors. So what does JAK inhibitor do? So these JAK inhibitors, it inhibits the JAK so that the cytokine signaling is blocked. So we have various JAK molecules, JAK1, JAK2, JAK3, and various interleukins, and as well as the interferon gamma, which signals through this molecule. So by blocking the JAK, you actually block the cytokine signaling. So this JAK1 and 2 inhibitor, ruxolitinib, have been extensively studied in hemophagocytic lymphohistiocytosis. So this is JAK1, JAK2 inhibitor, the paper which shows the effectiveness of this drug in a child with refractory hemophagocytic lymphohistiocytosis, even even when the disease is not in complete control with etoposide, dexamethasone, and anakinra. And this is a study from China, which shows that the use of ruxolitinib, it reduces the cumulative steroid exposure in children with secondary hemophagocytic lymphohistiocytosis. This is the follow-up study. This is the at discharge, the first month and in the second month. The red one is the control group, And the blue one is the patient group where they have used ruxolitinib, and they've shown that the corticosteroid load is reduced with the use of ruxolitinib. And this is an interesting case report where the child had acute renal injury where they could not use etoposide, and ruxolitinib has been shown to be of benefit in these patients. So in secondary HLH, especially patients in ICU who have renal injury, this is a drug to be can be used. So this is another interferon gamma blocker. This is a direct monoclonal antibody against the interferon gamma, the Imppellumab. This has also been used in children with HLH, and it's got its global approval for use in HLH in USA. Now, this is again an interesting article published in Oxford Rheumatology. The etiologies and management of hemophagocytic lymphohistiocytosis is a time for an updated protocol and targeted treatments. So this is a study done in adults, 29 adults with HLH who met the inclusion criteria. The authors have shown that in patients where the HLH 2004 protocol have been used, they have noted increased mortality. 73% patients in whom the HLH 2004 protocol have been used have expired, and 8% had recurrence of HLH. And 14 patients were treated with targeted therapy. So these targeted therapy included steroids, tocilizumab, anakinra, intravenous immunoglobulin, cyclosporine, rituximab. And in the targeted therapy group, 93% had resolution of HLH and only one died. So this study clearly shows the benefit of the targeted therapy compared to the HLH 2004 protocol in patients with secondary HLH. So this is the recent recommendations for the use of etoposide-based therapy and BMT for children with HLH. So this recommendation clearly states that the value of HLH94 protocol is less known in infection-associated HLH other than EBV, and care must be taken to differentiate neutropenic bacterial sepsis from HLH. So whenever you have a secondary HLH in PICU, bacterial sepsis would always be in our back of our mind, and using a chemotherapeutic drug in that setting would be detrimental. And HLH94 protocol is not indicated for leishmaniasis or tuberculosis associated HLH. And in macrophage activation syndrome, IL-1 inhibitors represent a valuable addition to cyclosporine and corticosteroid, and HLH94 protocol is not considered as a first-line treatment. So to conclude my talk, Etopocite, it carries both short and long-term side effects that are very significant, and clinically they can be detrimental. Cytokine blockade, it's an upcoming targeted therapy for HLH with fewer side effects. So I would probably consider cytokine blockade compared to HLH 2004 protocol in patients with secondary HLH. Thank you again.
Thank you, Vignesh. I think if Dr. Vasudha is ready. Yeah.
Good evening. Is my slide visible now?
Not yet.
I can share the presentation, Dr. Vasudha.
If you can share it, please.
Yeah, if you can stop screen sharing.
Okay.
Is it visible? Are the slides visible?
Yes, it's visible. Yes.
Yeah.
Okay. Good evening, everyone. I'll just move on quickly to my side of the debate. Being a hemato-oncologist, I will be trying to prove my point to using the HLH 2004-94 protocol for secondary HLH. So as we have learned from brilliant speakers over the last 3 days, HLH, CRS, MS, they are all acute and rapidly progressive disorders where the immune system is completely dysfunctional. It's a systemic disorder with cytopenias, excessive cytokine production, and hyperferritinemia. What is important to remember here is that it carries a very high mortality unless treated immediately. Next slide, please. So this is from Dr. Scott Khanna's paper. And the reason I'm highlighting this, although we all know about this, in a PICU setting, it's very important to actually understand and make the right diagnosis of HLH, because your sepsis, multi-organ dysfunction, and several inflammatory disorders can present with similar features like HLH. And what is important to note is that it's a constellation of the findings and the severity of progression that is important to decide if this child has got HLH or not. So the right diagnosis is very important, because sometimes we tend to use steroids and other anti-inflammatory molecules in disorders that are not like HLH, for example, in sepsis and MODS, and unfortunately lose the battle. Next slide, please. If you could go to the next slide. Yeah, again, we do know that there are two distinct entities traditionally, primary and secondary HLH. Primary being the ones that carry the genetic mutations, familial, and secondary being the ones that are secondary to viral infections, malignancies, your rheumatological disorders, and other infections like tuberculosis and leishmaniasis. Next slide, please. But what we need to remember, and what I would like to highlight, is that both primary HLH and secondary HLH are triggered by infections. And there's a significant overlap in the phenotype and severity between primary and secondary HLHs. And like we have learned over yesterday by Dr. Claudia, heterozygous mutations have poorer outcomes with severe phenotypes, and they do have recurrences. And younger age is again a big confounding factor. In a child with a younger age, it is a high probability of having a primary HLH and may be mistaken to have a secondary HLH. So before I would like to try and tell you the facts of secondary HLH or primary HLH treatment, we do need to ask always that, next slide, please. How sure are we that this is a secondary HLH, which is a very, very, a big confounding factor in the Indian scenario, because we need to actually wait for genetic tests, degranulation assays to be sure if we are dealing with a primary or a secondary HLH. Next slide. This is an excellent review in the NEGM, which actually shows us the downstream, the pathogenesis, pathophysiology for cytokine storm. But if you could see the topmost upper right corner, we have got the driver cells which come into action in the outset of either an infection or iatrogenic causes like CAR T cell therapy, or with an underlying monogenic and autoimmune disorder. And they drive the entire, downstream cytokine storm, thus causing the acute inflammatory effects and the organ damage. So I am fighting a contention for actually removing the source of these cytokine storm, which is targeting the T cells, and thereby avoiding the entire downward cascade, which exactly is what the HLH 2004 or the 94 protocol does. Next slide. And even in this entire, there is a beautiful chart about the different types of cytokines released with the different etiologies. And the most commonly seen one, for example, the primary HLH, secondary HLH, MAS, as well as the EBV-driven HLH, you can see that the CD8 cells are the main players. They drive the entire inflammatory cascade. So why cannot we target the CD8 cells, which are the source of these cytokines, instead of going downstream? Next slide. So with that, I'll come to the HLH 2004 protocol. So the HLH 2004 protocol essentially has three drugs: the dexamethasone, which is the steroid, the etoposide, and cyclosporine. Intrathecal therapy may or may not be used. With these three in mind, the entire treatment is propagated. But the first thing that I'd like to point out is whether it is a primary HLH or a secondary HLH, steroids are our go-to drugs. Next slide, please. So there is a modification of the HLH 94 protocol, because the cyclosporine upfront usage did not give us any, specific significant advantage. So this is a kind of a suggestion by El et al., including Dr. Hunter's group, which says that cyclosporine may be introduced 2 weeks later. And the initial therapy, the 2008 consensus recommendation, comprises of steroid, dexamethasone, etoposide, again the dose and duration, I will come to it, and intrathecal therapy only if the patient requires it and does not respond to the initial systemic therapy. Next slide. And of course, treat underlying triggers is a main part in secondary HLH. Next slide, please. So all these drugs, the steroids, etoposide, and cyclosporine, mainly cause cell death in activated T cells, macrophages, and dendritic cells. From Dr. Hunter's talk, also we understood the mechanism of etoposide so well. It is not just a chemotherapeutic agent. It induces pro-apoptotic cell death of activated T cells and macrophages and dendritic cells. And in EBV-driven HLH, the outcomes of etoposide are so good. Even before the use of rituximab, etoposide use in EBV-driven HLH gave very good outcomes. And cyclosporine A also causes reduced activation and proliferation of T cells. It may be used for preventing a recurrence of the HLH. Next slide. So why are we, if HLH 94 is really good, then why are we actually doubting it? So there are doubts on the efficacy of the treatment, the indication, primary versus secondary, the duration, and the toxicity and side effects, which I'll be addressing in the next slides. Next slide, please. So with regards to the efficacy, this is the largest study done for all HLH patients, the HLH 2004 study, which recruited 369 patients. And with the HLH 94 study, there are about 700 patients, which is the largest cohort for such a rare disorder. And you can see the efficacy of the entire regimen, which shows about 61% 5-year progression-free survival. And for those which were not verified familial HLH, this is for the overall cohort, the plot A. The second one with the not verified familial HLHs had a 64% 5-year progression-free survival. Next slide, please. So mind you, in this cohort of 369 patients, there were 168 patients with verified familial HLH, and the rest of them were treated as a secondary HLH. So this trial had included both patients with primary and secondary HLH. Next slide, please. And coming to etoposide, so what is the efficacy of etoposide? Is it only for primary HLH? So again, this is like Dr. Vignesh showed, as a recommendation for the use of etoposide-based therapy, and it can be used both in primary HLH as well as severe secondary HLH. So what do we need to understand before we use etoposide? Next slide, please. So does it have to be followed as per textbook, as per guidelines? So can it be individualized? With this, Dr. Yan Inge's talk gave a fantastic through light on this. It depends on the clinical context, the underlying condition, the age, the severity of the HLH. So of course, like I said, steroids are our go-to drugs for any kind of HLH, primary versus secondary. In fact, even in studies that have used cytokine blockade, most of them have used it with steroids and not by themselves. If you have a secondary HLH with a milder clinical course, there is no need to use a twice weekly etoposide to start with. You can use a once weekly etoposide. And in fact, you can use reduced dose etoposide to older teenagers and adults who you think would not tolerate it. And HLH 94 or 2004 does not mean that you have to use 8 weeks of etoposide. You can stop it if you see clinical improvement in your patient, by the time of which you would have got your genetic studies and understood whether this is a primary HLH, do you need to continue, or if the secondary HLH, you can stop. And I would like to dispute the fact that Dr. Vignesh said, in fact, etoposide can also be used in hepatic dysfunction. Hepatic dysfunction is not a contraindication for using etoposide. Next slide, please. What about cyclosporine A? Everyone is nervous about cyclosporine A, nephrotoxicity, press, and things like that. So yes, do not use cyclosporine A in the first 2 weeks with dexamethasone for severe risk of press. Early addition has not been beneficial seen by the HLH 2004 trial. It is a bridge to stem cell transplant, prevents reactivation. And a point to be borne is, in contrast to what is mentioned in the trial, lower trough levels, about 120 to 150 milligram per liter, help to minimize toxicity. Next slide, please. And what about CNS-directed therapy? Does every child need it? What if it's a secondary HLH? Do we have to subject them to an intrathecal methotrexate? Not necessarily, because even in the protocol, intrathecal methotrexate comes only after 2 weeks of systemic therapy. And by these 2 weeks, because of the good penetration of dexamethasone, most of the CNS symptoms would have improved. Next slide. Okay, so what about the third part, the potential toxicity of treatment? So definitely, yes, the syndrome of immune dysfunction itself, ongoing viral infections, steroids do kind of predispose the patient. So you need to start the patients on antifungal prophylaxis and pneumocystis jirovecii prophylaxis. The risk of AML, like my colleague pointed out, is much lower as compared to the morbidity and mortality associated with severe HLH. So in the HLH 2004, we had a morbidity of 40%, and 20% of them were before a stem cell transplant. And this patient who developed was a one patient in those 369 patients. So it's about 0.3% incidence of acute myeloid leukemia. Next slide, please. So why not cytokines? Why am I arguing for the HLH protocols? So like we have seen with all our previous speakers, there is excessive production of a large number of cytokines in hemophagocytic lymphohistiocytosis. There are different patterns of expression in, for example, in primary HLH, secondary HLH, that due to SOGIA, that due to SLE, etc. So will blockade of a single cytokine help? And this cytokine blockade does not again remove or impact the source of cytokine production. Circulating cytokines can be difficult to measure, and the real world scenario is the availability of the cytokine blockade and the cost. Next slide, please. So my conclusions are HLH is potentially fatal if not treated soon. So do we wait to procure the cytokines, or do we start off with the DEXA and then if the child does not respond, go on to etoposide, maybe in a dose modified pattern? There's considerable overlap in the phenotype and severity of primary and HLH and secondary HLH. So always bear caution in our setting. Steroids are the cornerstone of HLH treatment, which is included in the HLH 2004-94 protocols. Clinical trials, lack of them, availability and cost limit the use of cytokine blockade at present. I will leave you with a case scenario. This is a 6-year-old boy who presented to us previously absolutely well, who presented to us with fever of 10 days. There is periorbital edema and abdominal fullness since 3 days. On examination, he had pallor and a huge spleen. On an evaluation, he had a low hemoglobin, platelets were borderline, and the WBC count was also low. So he was admitted and started on empirical broad spectrum antibiotics, evaluated for infection. However, the very next day, deteriorated, developed hypotension with tachycardia, altered sensorium, shifted to the ICU. This is a typical child that we are talking about for this case. And repeat evaluation showed that all his counts had dropped. The ferritin was 9,800. So what do we do in this case? I would start on steroids, to be frank. This is a child who's really, really sick. I cannot afford to have any delay for him. So he was started on the HLH 94 protocol. And although his age was not so typical, we found that he had a compound heterozygous mutation in the UNC13 gene. And unfortunately had a relapse during the continuation therapy, a CNS relapse. And he received salvage therapy and went on to receive HSCT. The point of this case is that, yes, we do see a lot of compound heterozygotes, lot of genomic polymorphisms in our cohort. So we need to be really careful before labeling anyone as primary or secondary HLH. And HLH 2004 or 94 protocol, albeit with modifications, would be the safest and the best available therapy for all of us, at least in our setting at the moment. Next slide, please. And I would like to give credit to Dr. Scott Kana. He kind of helped me out for my last slide. And yes, this is the last slide. And I would like to draw your attention to the last chart. Next slide, please. Can you please press? Yeah, so someday, definitely, even I hope that we do have cytokine blockade as the first line kind of therapy for secondary HLH. But for now, we are not yet there. Thank you so much.
Well, I think this debate is hotting up nicely. I like the passion in both the debaters. We'll give them, I think, 2 minutes each to do a rebuttal. Vignesh, you go first.
Yeah, thank you, Dr. Vasudha, for the interesting talk. So I think the data is more towards the management of primary HLH, which Dr. Vasudha has talked about. Whereas in secondary HLH, it is the, most of the times it is the treatment of the underlying trigger with steroids, and IVIG does the major part of the work. But in some cases where the HLH is lingering on, so in those cases, I think therapy which is less invasive, less chemotoxic drug, either in form of a cyclosporine or in form of cytokine inhibitors, would be preferable compared to a chemotoxic drug like a etoposide, which has a lot of complications. And of course, if you have to block CD T cells, I think Dr. Randy Cron has commented, why can't you just give cyclophosphamide instead of just going with etoposide? And coming on to the point of the selective depletion of activated lymphocytes, in Etopocite. It's a good study, but I would like to place an argument that even patients with T cell immunodeficiencies have been shown to have HLH. So it is not just, I presume it's not just the activated T cells that is resulting in HLH. That could be a component of innate immune activation as well. Thank you.
Thank you, Vignesh. Dr. Vasudha?
Yes, ma'am. Thank you. So I did address Dr. Vignesh a few points in my talk as well. I would just like to say that cyclosporine is not going to act immediately. It's going to take time to act. And if we make modifications, even for dexamethasone, 10 milligram per meter squared is a really high dose of dexa. There are anecdotal reports which have used much lesser doses, maybe 6 milligram per meter squared. And then as soon as you get your response, you need to start tapering it down. So the point I would like to make is you don't have to go the whole length of the HLH protocol, but starting with something, especially when availability of the cytokine blockade is a real issue with us. I think that's a really good way forward, balancing, of course, the toxicities of dexa and etoposide. And I think I would like to end there.
I think that's been a fantastic debate. And I don't know, Chandrika is trying to set up if we can do a show of hands so that we can see which way people have been swayed. From my point of view, I think what this debate shows us options. It shows us the way to think through HLH, think through the different causes, think through what are the options you can advise for that clinical scenario, and according to what's available to you. So both speakers have made their points, and both speakers have actually given us options in our armamentarium. Thank you very much. It was delightful. And we'll move over to the next session.